we'll be starting the session. The station is respiratory, and the doctor that we have here is Dr. Nandini Biswas, ma'am. She is a senior consultant, Department of Pulmonology at Manipal Hospital, Kolkata. Over to you, ma'am. Thank you.
Thank you. Okay, everybody can see the screen well.
Yes, ma'am.
Good evening. I'm Dr. Nandini Biswas, a senior respiratory consultant. And today, I hope the session helps you and it'll be a good start towards preparing for the MRCP PACES examination. And being a pulmonologist, I'll give you a synopsis of how to examine the respiratory system. Now, before I start the session, MRCP PACES clinical is actually a very practical test, and it's actually more or less a real life scenario. How you should examine the patient, how you approach the patient, how you introduce with yourself to the patient, how you behave with the patient, how you examine the patient gently but correctly with empathy, and at the same time you do it professionally as well. So it's actually a very good exam in the sense it gives you a real life feel of what you should be doing. So we'll start, and just bear in mind that the MRCP PACES is actually very much a clinical examination. So you have a communication station, then you have all the systems, you have neurology, you have abdominal examination, you have cardiology, you have respiratory examination, and of course, communication skill as well. So, of all the stations, perhaps the cardiology and respiratory are the ones where you need to do a significant bit of examination. But at the same time, if you approach it in a systematic fashion, these are perhaps the more easier stations, but you need to have a system about how you get on with it. So, respiratory, just to give you an idea, so our breathing starts from the nose and ends very much in the lower lobe of the lungs and up to the diaphragm. So, the right lung has three lobes, the left lung has two lobes, the right lung is the bigger one, the left lung is the smaller one. This is what it feels like when you examine a patient with the chest open or when you want to do any procedure or thing. So, as you can see, the right lung has three lobes, the left lung has two lobes, the left upper lobe is the bigger one. So, if you have any pathology in the left upper lobe, the whole lung seems to have moved forward. So, if the left lung has consolidation or collapse, the left lung seems to have moved forward on the chest x ray. The right lung has the big right upper lobe, then the right middle lobe, and the lower lobe. So these are the anterior views, the sideways views, and the posterior views. Very important to have an idea, because as you get on, if you do medicine, if you do respiratory medicine, you will be examining the patients, you'll be doing procedures on the patient, you'll be doing chest and pleural aspirations. So it's very important that you have an anatomical idea of what the lobes are, where they're placed as you turn the patient, you examine the patient from front, back, or from the sides. So this is your right lung, the big lung, and this is your left lung, the small lung. These are the accessory muscles which I'm going to skip. The the most important muscle is of course the diaphragm, and which is something we have to all bear in mind. The rest, the intercostal muscles and diaphragm are the most important muscles. The rest are all accessory muscles. So, when you examine a patient, when you're asked to do respiratory examination, so the process starts as you approach the patient, as you approach the examiner and the patient. So the examiner will give a scenario. He or she will say this is a so and so or 60-year-old or 65-year-old lady or a gentleman, male patient or a female patient. Can you please examine the patient and let us know what you think is wrong with the patient or what his problems are? So this is how the whole thing starts. So what you do first, I've given a synopsis which I'll present at the end of the presentation, and I think it's very important that you keep that in mind and you rehearse in the same manner again and again and again. So when you do the rehearsal, you do it on your friends, you do it on your patients. When you go to the ward, you do it on your friends, and you keep doing it again and again and again till the whole process, the system becomes part of you. So always place the patient at 45 degrees. Make sure that the patient is comfortable and the head end is appropriate, that there's a pillow underneath the head, or etc. etc. Very important. And as you approach the patient and as you introduce yourself to the patient, you have to notice the patient and the room. So, is the patient normal build? Is the patient overweight? Is the patient cachectic? So, so your clue to as to what the clinical problem might be starts from your observation, the patient, the bedside, the surrounding. So, is the patient cachectic? Is the patient cyanosed? Has the patient got central cyanosis? Has the patient got peripheral cyanosis? Is the patient anemic? Has the patient got pallor? Is there tar staining, or what we commonly call nicotine staining of the fingers? So as you examine the hands, see if there's any yellowish discoloration of the fingers. Look for flap. There can be fine tremor which can be related to the beta 2 agonist. There can be a flapping tremor which can be related to type 2 respiratory failure or chronic carbon dioxide retention, which is very typical of COPD. Is there clubbing of the fingers? So you should know how to examine for clubbing. Raise your hand up to the level of your eyes. Look for the angulation of the normal loss of normal angulation within the nail, a nail bed, and then join the two clubbed fingers together and see if they're far more apart than what they should be. Always examine the JVP. The JV should be examined at 45 degrees. Make sure you do that and make sure that the patient is comfortable when you look at the JVP. You should always look for enlarged cervical lymph nodes. Examination of the lymph nodes of the axillary and the inguinal region can be a bit cumbersome and bit technically difficult, not technically difficult, can might be a bit challenging given the scenario where there are people around, the examiners around, other patients around. But always look for enlarged or absence or presence of enlarged cervical lymph nodes. If you can, what matters, you may skip this, but always look for a barrel shaped chest if this is possible. It might give clue to hyperinflation or COPD. If you can, you might skip this. You might look for spinal deformities if you can. And then you look for the rate of respiration, depth of respiration. Has the patient got normal respiratory rate? Has the patient got tachypnea? Is the patient got shallow breathing or normal breathing? Very important you do that because these are the only things that you will get. You won't get anything beyond that. Types of respiration you might skip, and then you go for palpation. So your palpation starts as you touch the patient. So when you proceed towards the patient, you wash your hands or clean your hands, you introduce yourself to the patient, you check the patient's name and ask permission at the same time. Is it okay? I'm such and such doctor. Is it okay if I examine you? So that is how you start. And as you approach the patient, hold the hands and start with the pulse, and then the rest follows. The palpation starts straight away. So amongst the palpation, I'll go through this again. I'll go through this within a stepwise fashion. Don't forget to palpate for the apex beat and the tracheal position. Very, very important. These are the different lines. I don't think we need, but good to know what the lines are. This is how you do a tracheal examination. You put your fingers, you palpate the trachea, you put your right index finger or the right middle finger on both sides of the trachea. Don't press too hard on the trachea because that can cause discomfort for the patient, and make sure that the space is equal in between both sides. So this is what you do the tracheal examination. Percussion of the chest, expansion of the chest is very important. So you do expansion, examination of expansion of the chest both anteriorly and posteriorly, and you divide the chest into three bits. So expansion area just below the clavicle, in the middle of the chest, and in the lower portion of the chest. You have to place both your thumbs in the middle of the chest and ask the patient to breathe in and out, and look for equal movement of both the thumb ends from the midline. If one moves away, the other doesn't, then you have to remember the pathology is on the side that does not move. Okay, so the same thing you repeat on the other side of the chest, on the posterior part of the chest. And the significance, so unilateral reduction of chest wall movements. There can be pleural effusion or fluid within the pleural cavity. You can have air within the pleural cavity. There might be lung collapse, lobar collapse, or anything else that might cause reduced chest wall movement. There might be emphysema as well, or extensive pulmonary fibrosis. So, the side of the chest that does not move or moves less compared to the side that moves normally is the one that is the abnormal side. So, palpation, then you have the tactile vocal fremitus. Now, the tactile vocal fremitus is examined with the ulnar side of your hand. You might choose to do tactile vocal fremitus and vocal resonance both. I would advise you to do one of the two because it's a question of time and you need to examine the patient in 6 minutes, and then the rest 4 minutes are to present your findings, mention what your impression is, and for cross questioning as well. So it's examined with the ulnar side of the hand. You have to do both on the anterior chest and the posterior chest. Divide the chest into three bits, and you ask the patient to repeat 99. So upper chest, middle chest, and lower chest. So if there's fluid or if there's some hyper expansion of the chest, if there's emphysema or air or fluid within the chest, then you get decreased tactile vocal fremitus. If there's consolidation or the lung is solid, then you get increased vocal fremitus. That's all you need to remember, nothing beyond that. So that goes another part of the palpation. Then you go for percussion. The percussion is again the same thing. You examine percuss both the anterior chest and the posterior chest, and you percuss both sides from the midline, so the right side and the left side. Again, you can divide the chest into three parts. So you can go below the clavicle, middle bit of the chest, and the sides of the chest. The same, then you turn the same you go further, then go to the back of the chest. You again go in the top bit, the middle bit, and the lower bit. Okay, so that's it. You can get what we normally look is normal resonance. That is same on both sides. That's there you get dullness on percussion, which is where if you have raised hemidiaphragm or a pleural effusion, or you can have hyperresonant percussion when you've got emphysematous changes on the lungs. So that's what is written: dullness, resonant, which is normal, hyperresonant, that is tympanic, when there's pneumothorax that can cause tympanic breath sounds. We normally don't tend to give pneumothoraces on in examination, so what you need to remember is dullness that usually comes in exams. So these are very important things, and you need to make a mental note of that. Then you auscultate the lungs and you look for normal breath sounds. So, so this is the stethoscope. So let me skip this. These are types of breathing. So what you need to auscultate for is breath sounds. You either get normal breath sounds, you get absence breath sounds, or reduced breath sounds, or you get bronchial breath sounds. So normal breath sounds is normal. Absent breath sounds is when you have a pleural effusion, some sort of fluid within the lungs. The breath sounds might be absent or they might be reduced. And if you've got consolidation on your lungs, then you would get bronchial breath sounds. Make yourself familiar with the quality of breath sounds. You have to keep listening. So normal breath sounds is where the inspiratory phase is louder than the expiratory phase, because the expiratory phase is a passive breathing. Absent is when you don't hear any breath sounds at all. Reduced is it's reduced from what is normal, and bronchial is when the expiratory phase is longer than the inspiratory phase. So these are the three breath sounds you need to remember. And then what added sounds do you get? You can strider. We don't give patients of strider an examination because a really strider is a medical emergency. So what you would normally get is crepitations, or what we call crackles. If we crackles, and again it could be inspiratory crackles, expiratory crackles, fine crackles, coarse crackles. These you can get in the context of COPD mostly, very rarely in case of asthmatics, but asthmatics who are not exacerbating, who are recovering maybe from exacerbation and who are stable. Rubs are normally seen when you've got pleurisy or pneumonia or consolidation. So rubs are again rare, but if they have a rub and the patient is stable, then you are expected to get one. So it's a leathery noise when you listen, when you auscultate the chest. You can get it more in both phases of your breathing, but it's typical when you rub a leather piece against each other. That's the rub. So what you're expected to get is crepitations and wheeze. So vocal resonance, I wouldn't bother too much. So vocal resonance, bronchophony, whispering pectorally. These are when the even the low pitch sounds get transmitted through solid lungs and can appear louder than it normally would be. And egophony is when the quality of the sound changes completely. So I probably wouldn't or worry about too much about this. The way to do is inspection, then palpation when you do a general examination, when you feel for the apex beat, then you look into chest expansion, then you do the percussion, then you do a tactile vocal fremitus, and then you go for auscultation, and then you present your findings. So, this is very important. This is the synopsis of how you should approach. Obviously, confidence is the key. So, keep rehearsing again and again and again. And so, to the point that it becomes a part of your system, a part of your examination. These are difficult examination, but again, at the same time, not difficult examination, because nobody expects weird, wonderful diagnoses from you. That is something that happens much later in life when you're a senior doctor. But clean your hands, um, don't frown, introduce yourself to the patient, ask permission to examine, and when the patient says yes, then thank you. Tell that thanks for letting me examine you. And then, as you approach the patient, an overall inspection of the room and the surroundings and the patient is very important. So, what do you look? So, look around the bed. Look and see if the patient is comfortable. Is the patient seated comfortably at 45-degree with the head end up? Is there evidence of oxygen, walled oxygen or oxygen cylinder? Are there any inhalers by the bedside? Is there a nebulizer machine? Is there a sputum pot by the bedside? Is there a chest drain or something bubbling, a tube coming out of the chest? As you approach the patient, are there any visible scars? Are there scars of previous lobectomy or pneumotomy? So these are very important. Has the patient got pursed lip breathing? Is there indrawing of the intercostal muscles? So as you inspect the patient, you can actually get clues into the underlying clinical condition, which is what you're supposed to examine and explain to the examiner. So this is very important. Spend few minutes looking around. Nobody is going to fault if you do that. They will know that yes, you are a conscientious person, you're an observant doctor who is actually inspecting the surroundings before you approach the patient and start examining. So don't jump. We are all nervous when we take the PACES clinical examination, but don't jump. Take a few seconds, 4 5 seconds to look around, look who's around, look at the examiner, look at the patient, introduce yourself patient, and then say, as you approach the patient, introduce yourself, ask permission and thank, and that gives you plenty of time to have a look around. May see if the patient has got intravenous, if the patient is on IV, has an IV access line, if the patient is on antibiotics, has the patient got fluids running. So these are very important. So any abnormality in the patient's respiratory pattern, if the patient uh, tachypnic, has the patient got pursed breathing? Has the patient got indrawing of the intercostal muscles? Then hold the patient's hands. It gives an idea of what the if the patient temperature is normal. Check for pulse. Count the pulse. Check for the pulse. Look into cyanosis. The patient peripherally cyanosed. Turn the hand around. Look for any tar staining or nicotine staining. Look for clubbing. So as I said, examine for clubbing. Raise the fingers up to the level of your eyes. Look for the angulation of the nail and nail bed. Ask the patient to fold the two fingers together and look for the loss of angle. Are they far apart, or are they touching each other? Look for tremor. Look for fine tremor as you hold the hand. Then you ask the patient to stretch his hands out, cock up the hands, and examine for 10 seconds to see if there's flap of the outstretched hands. Very, very important. Please do that. Show the examiner that you know what carbon dioxide retention tremor is, and you're checking to see whether the patient has got that or not. So acting correctly, following each step is very important. You're not expected to get the correct diagnosis straight away, but at least you're expected to show to the examiner that you're examining the patient in a stepwise fashion. Then check for pallor. Pull down the eyelids. Tell the patient that you're pulling down the eyelids. Ask the patient to open the mouth. Check into the tongue, back of the tongue, and the inside of the mouth. Then, when the patient asks the patient to sit up and look for cervical lymph nodes. So, underneath the mandible, down anteriorly in the neck, posteriorly in the neck, and look into the supraclavicular region. Very, very important. Make an effort, show to the examiner that you're palpating, looking for enlarged cervical lymph nodes. Then you put the patient back in 45 degrees and look for JVP. Ask the patient to look on the opposite side and look for the pulsation of an internal jugular vein. If you think they need to do look for hepatojugular reflex, then ask the patient if he or she has got any pain in the abdomen and gently press around the liver area to see if the JVP, the pulsation is accentuated. Then with the patient sitting in the 45 degrees, look for tracheal position. Warn the patient that you're going to feel for the trachea, and then you need to put your fingers on both sides of the trachea. Say that this might be a bit uncomfortable, but you'll do your best. So do that and then look for pedal edema. Also mention that you're pressing on the shin bone, that it might be a bit uncomfortable. Then you press for a few seconds and roll your finger to see if there's any dent on the shin bone, which would indicate pedal edema. So this is how much you should do. It feels like a lot, but as you start doing it, you keep examining on your friends, you will see how sleek and how well rehearsed you become. So very, very important. It all takes few minutes only, but it can be a wealth of information, and then it already gives the examiner a good impression that yes, this doctor knows what he or she is doing. Then you examine the anterior part of the chest, and then you go follow the whole protocol into the posterior part of the chest. So With a 45 degree, you ask, place your hands, divide the chest into three, place your hand on the anterior part of the chest, and ask them to take a deep breath in and out. So, and see if the ends of the thumbs are moving apart equidistantly from each other. If one is moving less than the other, then that's the abnormal bit of the lung. You divide the chest into three zones and you do it. So once when you start doing the anterior chest, finish the whole examination of the anterior chest. Because if you keep moving the patient back, front and back, sitting, resting at 45 degrees, and then sitting up again, and resting at 45 degrees, and sitting up again, then it looks a bit cumbersome. Once that is done, look, start percussing. We should ideally do tracheal clavicular perfect percussion, but that is a bit painful, so I wouldn't advise you to do that. Again, percuss both sides of the chest. Divide at least into 3 to 4 zones. There's the upper bit, middle bit, and the lower bit near the costal margins. Once you do that, then look into tactile vocal fremetus. You're welcome to do vocal resonance, but in the absence of time, choose one. I prefer the tactile vocal fremetus. So, with the ulnar side of your hand, examines, ask the patient to say 99 and see whether it's normal, hyper resonant, or reduced on one side. Okay, and that gives a clue as to whether there's fluid in the lungs or there's solid lung or is it normal on both sides. Once you have done tactile vocal fremeters, then you take your stethoscope. Then only you take your stethoscope and you listen to both sides of the lungs. Then you ask the patient to sit up and do the same steps that you did with the anterior chest. So you look for chest expansion on both sides. I can divide the lungs into 3 zones and do it on both sides. See if the fingers are moving apart equally from each other from the midline. You percuss, very important, because if you've got pleural fusion, then the percussion to look into dullness or reduced percussion note will be easier on the back. So if there's a pleural fusion, there's a patient with pleural effusion, and if the patient is stable but has good clinical signs, make sure you can be certain that that pleural effusion person or patient will come for examination. So when you do the percussion, bear in mind that it's easier to percuss and find out percussion notes on the posterior part of the chest. So concentrate when you do that. The same applies for tactile vocal fremeters, so say 99 on both sides on the posteriorly as well. So these are the few things that you have to bear in mind. What do you think? If there's a question of dullness or reduced, it's easier, the reduced breath sounds or reduced tactile vocal fremeters, it's easier to examine often on the posteriorly. So make a mental note when you do that. Only when you I've done all these 3 steps because, as I said, remember you have to show the examiner that you're following the examination pattern. Then you take your stethoscope and look for normal breath sounds, reduced breath sounds, absent breath sounds, bronchial breath sounds, or are there any added sounds? Is there respiratory wheeze? Is there crepitations? And if there or there bronchial breath sounds? Bronchial breath sounds but unlikely, but you might if the patient is stable. And if there is wheeze, then you know we are dealing with chronic lung disease, airways disease. And if there's crepitations, are there inspiratory crepitations, expiratory crepitations? Are there fine crepitations, coarse crepitations? Are they changing, disappearing with coughing, or they remain the same? So this is also all this you have to do in 6 minutes. And when your time is almost up, I think they'll give you a warning. There's 1 minute left or so and so. Following which you have to present your findings and then you have to say what you think is wrong with the patient. So once the examination is complete, cover the patient and thank. And when asked what else you would like to do, so thanking the patient, making the patient comfortable is very, very important. In MRCP scenarios, it is expected that you will have good etiquette, good bedside manners, that will be courteous with the patient. So very, very important. If you make mistake in this, then you are in trouble. So depending on what you have found out, you obviously say, I'll look into the observation charts. So I'll look into blood pressure, what the pulse rate is, which you've already examined, oxygen saturation, whether you look into chest X-ray, uh, lung function test, if you think it's airways disease, chronic lung disease, COPD, or asthma, and look into other findings. I would like to know what the patient's radiology is, what the patient's sputum examination results are, etc., etc., etc. So this is what you do, and then you have to tell the patient, tell the examiner. So my impression is, I believe, so not I think, my impression is, or I believe that this patient has got such and such problem, that this patient has got COPD, or the patient has got pneumonia or lower respiratory tract infection, or the patient has got pulmonary fibrosis or bronchiectasis, because the patient has got uh, coarse crepitations which reduce with coughing or which disappear with coughing, or that the patient has got clubbing, and the patient has got sputum port by the bedside, and I think he or she has got bronchiectasis, and you present, go on and on and on and on, and then further discussion revolves around that. So if you say, for example, if it's a question of pulmonary fibrosis and it's a male patient who is older, and then the examiner would ask, what do you think the reason for his pulmonary fibrosis is? And then the discussion will follow. Then that you have to take smoking history, and it could be due to idiopathic pulmonary fibrosis, which is associated with male patients over a certain age with a history of smoking, active or passive, and this is what you would do. Then the examiner might go, so what investigations do you think you're going to do? And then you have to mention CT scan, and if are there any rheumatological features or any joint pain or anything, then whether you want to do rheumatoid factor or any of the other autoimmune tests to establish the diagnosis. And then he or she might ask for management, etc., etc., etc. If this is a bronchiectasis, then obviously what is the cause of bronchiectasis? Is this post-tubercular bronchiectasis, or is there COPD associated with bronchiectasis, or as the patient has had any childhood illnesses that is causing bronchiectasis? And then the investigations and the management will follow that pattern. If it's COPD, then obviously COPD, how do you manage COPD? What are the causes of COPD? And we have lots of causes for COPD, so please read up. It could be childhood respiratory illness, it could be smoking related, it could be environment related, it could be post tuberculosis related, it could be alta. So read all this up, and then you can answer accordingly. And then if there's pleural effusion, again, it's good thing to have, because then you can say, I think the patient with pleural effusion. If there's a drain, then you can point out to the drain. And then the discussion, what findings do you have? Reduced breath sounds, reduced dullness to percussion, or reduced percussion noise, reduced tactile vocal fremitus. And my impression is, so what do you then the discussion really, what do you think the reason for unilateral pleural effusion is? So, there's a wealth of things you can say, whether, this is lung cancer, infective, tuberculosis, parapneumonic, lots of things. Okay. So, further discussion revolves around what your findings are. Doesn't take long, it's about 4 minutes and nothing beyond that. So, common scenarios for PACES. So, as we say, we often struggle to find good patients with clinical findings, because we expect the candidates to have, a good, reasonable case, which has got good clinical findings. So, it's good for the candidate and good for the examiner. So, what are the common scenarios we get? So, you're not given any fancy things. So the common things are COPD, so general examination, inhalers, nebulizers, oxygen, NIV machine around the bedside. Lot of COPD patients, these are stable and on NIV. Inspection, pursed lip breathing, maybe hyperresonant vocal resonance, or hyperresonant reduced tactile vocal fremitus, or wheeze or quiet breath sounds. So this is what you get in COPD. If it's a bronchiectasis patient, you definitely get nebs, maybe oxygen, maybe a channel, definitely very often a sputum pod, and maybe as the patient talks, as the breathes in and out, you might get a bit of rattling noise in the chest, and then coarse crepitations. Very, very important for bronchiectasis. So always bear in mind what cases you can get. And I don't think you are going to get anything beyond that. Pulmonary fibrosis, ILD is a very favorite thing of ours. So again, bedside oxygen, nebulizers, clubbing, possibly on inspection. You might get rheumatoid fingers, and so pulmonary fibrosis due to connective tissue disorder, rheumatoid arthritis, which is again a very good case to have because you can do a good examination findings, lot of talking that you can do. So fine inspiratory crepitations bilaterally might be cachectic, may not be cachectic, may be abnormal hands, rheumatoid nodules, on the near the elbow. So these things you can get. Then again, lower respiratory tract infection, pneumonia, you won't get an acutely unwell patient, but the patient who is recovering from pneumonia or lower respiratory tract infection who's still got clinical findings, again, might be a good case to have. So IV access, oxygen, NEBS, crepitations in the affected zone. Very important. You might get this as well. You might get this quite a lot. Other cases, asthma, again, unlikely when the patient is acutely exacerbating, so you won't get acute asthma. However, once the asthma is recovering, so it's safe and the patient is agreeable, and it's safe to keep the patient for examination purposes. Look for clues, look for bedside peak flow meter, look for oxygen, look for nebulizers, look for inhalers. The findings might be normal, but you might get a few expiratory V's as well. Pleural effusion, if the patient is stable, you will definitely get it. So look for clues, look for ICD, look for cervical lymphadenopathy, you will get very good signs. Dullness to percussion, reduced vocal resonance, reduced tactile vocal fremiters, reduced or absent breath sounds to auscultation. So, uh, so these are generally the cases you would get. Very important. So learn learn these few steps by heart. Make it not by heart. Keep on practicing, cleaning your hands, introducing to the patient yourself, the patient, asking permission and thanking for letting him examine the patient. Overall inspection of the surrounding and the patient, looking around the bedside for added clues, sputum pond, and clues to the underlying clinical condition. And then again, patient's respiratory pattern, breathing normally, pursely breathing, enjoying of costal margin, or the patient taking has the patient increased respiratory rate, a shallow breathing. Hold the patient, check the pulse, and then gives a lot of information: cyanosis, nicotine or tar staining, discoloration, clubbing, tremor, so many things as you hold the hand. Then make an effort to look for clubbing and tremor, flap. Then check for pallor, go into the neck bed, check for pallor, tongue, cyanosis, JVP, lymph nodes, all in one sleek movement. Then go for tracheal position and then pedal edema. um, Ask permission that you what you're going to ask permission, inform what you're going to do next, and it should be part of your being. This does not take time, it can happen very rapidly, one after the other. Then you examine the anterior chest, do the whole examination of the anterior chest, and repeat the whole thing in the posterior chest. So chest examination, percussion, vocal fremiters or vocal resonance, whichever you fancy. I would avoid one over the other, but for the sake of time, auscultation, you can do both if you want to. And then posterior examination, follow the same steps. Then once examination is complete, you cover the patient and thank and say what else you would like to do or what you would like to see. And then you present your positive findings, no negative findings, that my impression is or I believe. You may be wrong, you may be right. But this is what you should be logical. So this is what you found, and this is what you think it is. May not be the case, but this is what you. So there should be some logic when you say what you think is wrong with the patient. And further discussion revolves around what you would do with the patient, what investigations you would do, how you would manage the patient, etc., etc. Again, I'm saying it's divided between 6 minutes and 4 minutes. So if you can present logically, if you have judicious, like I mentioned, logical, don't make up science, never make up science, it'll be pure faith. What you can't find, you can't find. So that is fine actually. And the crepitations particularly keep moving, the V's might disappear. So I might have examined the patient in the morning, there might have been V's. Now the patient has had another dose of nebulizer before the candidate goes examine, the V's might go away, and that's fine. Okay, and so further discussion revolves over what you find, what you found, what your impression is. So what you would like to do with the patient, how would test you would do with the patient, and how you would manage the patient. And these are the common scenarios. I do not think you're going to get anything beyond that. COPD, bronchiectasis, pulmonary fibrosis, our favorite, and then lower respiratory tract infection or pneumonia, asthma, once that asthma is recovering, and pleural effusion. So now I think that pretty much covers my uh, teaching, unless you have any questions, please.
Ma'am, good evening.
Good evening.
Ma'am, for the case of pulmonary fibrosis, it could be because of some different autoimmune disorders.
Yes.
For example,
yes.
for the scleroderma case. So as you was talking about, some patients might not getting the crepitations. Can it be possible, like we are doing the examinations, we are getting all the findings of the scleroderma, but couldn't able to get the fine crepitations in the basal, which is supposed to be a diagnostic for the night?
Yeah, that can be quite possible. You're supposed to get it. Sit
Yeah,
the
in that
patient.
scenario, how should we proceed to the examiner?
So, this is a backward clue. So, there's an autoimmune connective tissue disorder.
Yeah.
You're appearing for a respiratory examination. So, more than likely that the patient has got pulmonary fibrosis related to the connective tissue disorder. So look for surrounding clues, look for hands and, tightening of the mouth, or, skin
Yeah,
tightening
if it is
around
an
the
obvious
fingers.
weaky,
Yeah,
that's
but
what my
again, again, it might be pulmonary hypertension, could be. So there might be peripheral edema, JVP. So the way you would approach it, so this patient has got connective tissue disorder, possibly scleroderma. I would expect that the patient has got lung disease associated with connective tissue disorder, most likely pulmonary fibrosis. However, I'm unable to elicit any crepitations at this point of time. Then the examiner might say, is there any other lung condition that you can have with scleroderma or pulmonary fibrosis? Then you can say, you can have pulmonary hypertension, etc., etc. Okay?
Okay. In that scenario, our marks is not going to get deducted.
No, not at all. What we sometimes tend to do is, oh God, did I hear it wrong? So when you finish the examination,
Okay.
I quickly go and listen to the patient as well. Do you know what I mean?
Got it.
So as an examiner, so
Yeah.
once my
Actually,
cross
what happened,
questioning,
ma'am, to be frank, like I had a case about that. So it was a scleroderma clinically. I'm getting all the peripheral signs about that, even the peculiar of the skin tightening and all, beaks, nose, and all. So I just explained about the same thing as was supposed to be, like this is a scleroderma. I believe it could be of pulmonary fibrosis, but however, at this moment, I haven't appreciated the crepitations.
I am unable to elicit any crepitations.
Yeah.
Okay, that's what you say.
But in my feedback, it was shown as the I didn't examine about the crepitation, so I got a little worried about it.
I would certainly not advise to make up signs. Okay.
Because I was not sure. Okay, I have examined a bit closely about that patient, because I was expecting to have the crepitations, because all the signs were going towards this pulmonary fibrosis. But it doesn't turn to me. So I just mentioned the same thing to the examiner.
And?
Yeah, the marks has been deducted. So I don't know whether I missed or what happened, how to proceed if it is in future in the similar way of the cases.
Normally, the way the exams happen, we examine the patient ourselves. before we
Okay.
call the candidate, so before the exam starts, we examine the
Okay.
patient, and we discuss, which patient, what signs the patient has, and what to so when I'm examining you, I actually know what the signs are because I've examined myself. Okay.
Okay.
And we always tend to do that. So I'm not able to tell what happened there, but if I would certainly not advise to make up, crepitations or any other extra findings. And also remember, if you do not so great in one scenario, doesn't mean that things won't turn favorable. So there are other scenarios that you can do properly. So always remember that, but do not make up, say that, I'm not able to appreciate, then, I would normally say, has probably this patient has got pulmonary hypertension related to systemic sclerosis or scleroderma. Okay.
Yeah.
So that's what I can say. But, making up signs is certainly not advisable because that will be a clear fail. Okay.
So then that was on my right approach. I said about for the as of now, I'm not able to hear
Yes.
the
Yes,
crepitations.
that's an
Okay.
absolutely right approach. An absolutely
Okay.
right
Okay.
approach.
Thank you. Thank you, ma'am. Thank you.
Thank you. Always remember, all of you, these are the very few cases that you can get. And it is how well you examine, how sleekly you examine, how methodically examine, that's going to give the first impression. Even before you open your mouth and say, I believe, or my impression is this patient got such and such. So we mark on everything. Not only, no, it's not that you have to get it. No, obviously, if you make a very wrong, big mistake, that's different. Or if you're rude with the patient, that's a different
Okay.
issue altogether. But our impression depends on everything: your bedside manner, your examination skill, how you handle the patient, how sleekly you do it. That shows us you've practiced, that you do it on a regular basis on the wards. Anybody has got anything else to ask? Obviously, once you start, the clinical examination courses, or you do your practices, remember these steps and keep on doing them, keep on doing them. I know we all have busy lives, but keep on doing them. There are only very few systems we examine. So if you do them on a regular basis, the whole system gets imbibed within yourself.
Thank you,
I
ma'am. Thank you very
I
much.
wish you luck. You should be fine. Just keep on practicing and you will get there. Thank you.
Thank you.